Happy Thursday, everybody. It's bright and early here, but it really is bright. I think the beginning of summer is upon us, and I love nothing more than the sunshine that it brings. But the truth is that we are all very, very lucky, I think, to be able to hang out here, an eternal source of nutrition and warmth and growth. And I couldn't be more thrilled to be hanging out with you all today. I get to go discuss with not with a typical setup on Thursday where the goal is to take a junior learner and have them be more and more comfortable voicing their thoughts out loud. But actually, today I might be the junior learner. I am very, very excited to go discuss with our beloved Mengyu. And we'll hand the mic to you, Mengyu, just to update folks on how you're doing and what's new in your life.
Yeah, thank you for such a generous introduction. I don't know if I'll ever feel ready to be co-discussing with Rabih or, in general. Had another dream where I was uh, going to deliver a talk, but I haven't prepared the 15 minutes prior to that. I don't know. I think it's subconsciously. But I'm learning to make peace with myself, recognizing life is so busy, but just always finding the thread where I can stick to, which is the CP solver space that I can always learn something new every day and try to stick to some habits, but otherwise try to enjoy life with family so yeah.
What have you been enjoying recently? What's been the highlight?
Um, as mentioned earlier, snuggling with baby in the morning, I think is one thing that I really, really enjoy and try
Yeah.
to be more, pay more attention to my own health, and which
Yeah.
includes scheduling a wisdom teeth removal tomorrow,
Ooh. Oh,
which was inspired by Ravi after a chat.
oh, nice.
Finally
Amazing.
postponed after postponing it for so long.
Oh my gosh. It was actually way easier than I thought it was going to be. Um, I only had one wisdom tooth, which goes to show you the amount of wisdom I have truly. But it was actually effortless. So I hope your experience is similar to mine. I really, really do.
That's very reassuring.
Yeah, fingers crossed. I see um, so many people here who are not part of the academy who have their videos off, and it's such a rare thing. I'd love to say hi to you all. Amna, do you mind telling us where you're calling from?
Sure. Thank you very much. I am just like brand new here in the
Yeah.
forum. It's my third session here, and I reached out to this forum by looking at the Twitter.
Hmm.
So, briefly, I thank you very much for asking me to introduce myself. I am calling from Rochester, Minnesota. I'm working as a research trainee at Mayo Clinic, Rochester, and
Amazing.
I am gonna applying this cycle in internal medicine residency, and
Amazing.
I just like find this forum that is that can just like keep me in touch from clinical standpoint as
Yeah.
well. So
Right.
this is something really interesting to me, and I just have like couple of lectures before, and I find like very curious that I should stay connected here.
Oh yeah, wonderful. Well, very, very happy. Thank you for telling us a little bit about yourself. Excited to get to know you better. I also see
So,
Matthias. You have your video on. Hi, Matthias.
Hi,
Where are you calling from?
I'm calling from Brazil,
Amazing. Whereabouts in Brazil?
and I'm in Belém do Pará, in the North region.
I see. Incredible. And how did you come to know of this space?
So I was recommended by Bruno Lima.
I
He
see. Yeah, yeah, yeah.
he gave the recommendation, and I saw some videos
Incredible.
and grew quite fond of the discussions. So I'm here to listen
Yeah.
and
We're very, very glad to have you. Thank you for joining us. And
thank you.
last but not least, Magnus, I see your videos on too. Hi there.
Hi there. I'm Magnus. I'm from Copenhagen, Denmark.
Nice, incredible.
Been following the clinical problem solvers for some years now, but
Wonderful.
thought it was time to get
Yeah.
online.
Yeah, well, I'm so glad you're here, all three of you. It's a pleasure to meet you all. And I know Rahul has an incredible case for us. So before I introduce him, and we get going, I wanted to thank the two people who are making this happen. Hiding with his video off, probably because it's very early in the morning, is our want to know. Oh, hi, is Noah. Noah, do you want to give folks a quick update on how your life is going?
Life's going good. I'm gonna pack my bags. I'm gonna
Yes.
visit Rabih this weekend.
Woo!
Super excited to go to San Francisco. It's gonna be amazing.
Gosh, you have no idea. Well, I'll tell you more offline. Actually, I shouldn't say this in public. We're very, very excited to have you, and I'll just say that a lot of prep work is going into making sure you have a good visit, and I'm doing a very small fraction of it. Um, very, very excited to have you here, Noah, very soon. And Lyra, you're doing teaching points. Do you want to say hello?
Yeah, hi everyone. My name is Lara. I'm a medical student from Russia. Yeah, happy to be here.
You have to give us a cat update. What's new?
He just ate and he's very dramatic, so he may be screaming in the background. Yeah.
Really? Why?
Yeah, he screams a lot. I don't know why. He really needs a lot of attention.
You know, Lyra, cats have been presented in VMR before, and hopefully your cat doesn't have a serious medical issue, but maybe we could try to dissect the reasoning behind the screaming someday. That'll be a fun exercise. But not today. Today, Rahul has a case in store for us. Rahul, do you want to unmute, update folks on your transition to intern year, and then we can jump into your case?
Hello everyone, I'm Rahul. I'm an incoming PGY1 into the Waterbury Hospital. And update, right now working on the visa process and current onboarding process, as well as some shopping and just preparing for the intern year. I'm very excited.
How does it feel to say that sentence that you're an incoming intern?
I would say honestly,
Yeah.
It's directly proportional to the amount of hard work we put in. And always, especially for IMGs, the path is very difficult.
Right.
But one thing which motivated me,
Yeah.
now all the knowledge which I've gained throughout the medical school,
Right.
from PP solvers, now I can apply directly to my patients.
Mm.
So that's a very humbling, and I feel it's a great opportunity.
Yeah.
Yeah, to take care of American patients. That's a
Wonderful.
privilege.
Wonderful, wonderful. Absolutely. I love that. At the risk of irritating our YouTube folks, I see somebody else has turned their video on who's not part of the team. Frederick, hi, I see you have your video on. Do you want to tell us a little bit about yourself?
Hello, everyone. I'm Frederick. Been following with clinical problem solvers for almost 3 years now.
Wow.
I'm
Gosh.
calling
That's
in
more than
from
me,
Uganda.
Frederick. Jeez.
Hmm?
Sorry, I interrupted you because that's more than me. 3 whole years? Wow.
Yeah, 3 whole years. But most of the time, I've just been following on YouTube, and now that the time is okay, I can follow during
Wonderful.
daytime.
Very happy.
Thank you so much.
Very, very happy. Where are you calling from, Frederick? I'm sorry, I interrupted you when you said that.
I'm calling in from Uganda,
From Uganda. Wonderful.
Eastern Africa.
Wonderful. Very, very happy to have you. Rahul, the stakes are up for your case. We have a guest from Mayo, we have a guest from Brazil, we have a guest from Denmark, and now Uganda. So I hope you're not too nervous, but let's have some fun.
Sure, Ravi. Thank you so much. I just want to give a quick update to all the audience who are participating today. I did not see this patient directly, and I'm presenting this case on behalf of Yusuf, one of our academy members, and who saw the patient. Now, coming back to the chief complaint, the chief concern is confusion. I really want to give some HPI. He's a 75-year-old male and presenting for confusion, and his family endorses that he was okay at baseline and able to do all the activities by himself, and is very conversational. But lately has been feeling weak with body aches, and his wife has to do more job for the daily activities. And today family also noted an episode where patient was stuck on the toilet for an hour and could not get up or respond to the wife beyond yes or no answers. And his wife called EMS, and they noted some right arm shaking as well. And the patient states no in response to the question for any focal pain. This is the end of my first report.
Yeah, thank you for such wonderful history. I think an elderly person presenting with confusion is not an uncommon chief complaint, and where I think I'm getting a sense of a subacute course rather than a hyperacute, maybe acute or subacute. So I'll clarify more about the timeline. I think for confusion, I always like to use the mnemonic mist to help me organize my the history I'm going to take and the labs I'm going to get and so I'll just like maybe quickly review the MIST framework for metabolic, think about all the labs you can see on chemistry and in addition, blood gas, if there's, and then endocrine workup, and bowel retention, urine retention are another sneaky causes that we could think of. And infection will ask for any clues for infection. And here we hear some body ache. So I think that could be a clue for viral infection. But gonna to ask more any like fever chills or things like that. And then structural etiologies, I think a CT scan would be usually like where we start. We haven't, I'm trying to usually think if there's any localizing symptoms. And here, the only clue I'm seeing is there's a right limb shaking, which, you know, could be like myoclonus, which could be still again due to metabolic or generalized causes, or could be I don't know if it could be a clue for like a localized seizure or something more localizing. And then toxin, I think definitely scrutinizing the medications, including what he might be at risk for withdrawal or what he is taking as a new medication or not, and then potential exposure to toxins. So start by, you know, exploring the case by around those. And then in the end, like definitely focus on what's left is image negative, including, and those usually require advanced workup to define, like including advanced imaging or EEG, or and then psych problems. And it sounds like he may have some underlying cognitive issues. It sounds like he's not fully clear at baseline, but I think clarifying more, but that would suggest that he might be at risk for any insult that would cause him to have a more acute course of confusion. Those are my thoughts now.
I think they're absolutely superb. And honestly, Mengyu, all of the workup, as you alluded to, for altered mental status when you first meet the patient is to get blood work to understand the extrinsic causes. We don't do much investigating of the brain directly itself unless the patient has trauma with a head CT. And so all that happens in the first hour is adjusting our pretest probability that there's something extracranial like a UTI or hyponatremia. And I think I'm wondering myself, what is the pretest probability that 1 hour from now, when the labs come back, we'll have an answer? And in most cases, the pretest probability is pretty high. In some people, we find all the things that you just mentioned. And I would say there are 4 reasons why in this patient, the pretest probability is not as high as it usually is. I think the first is the first line, the fact that this patient is functionally independent. And that often means that the degree of disease required to get a patient who is strong and healthy from the beginning to be very, very confused is high. So it would take a very severe systemic issue. In stark contrast, a tiny little stroke in the frontal lobe or in the brainstem can cause a similar picture. So I think how healthy it is at baseline reduces the probability of extrinsic trigger. I'd say the second is the fact that you alluded to, there's a hint of focality here with the right upper extremity involvement. The third is, I think, a very subtle but important point, which is when patients have extrinsic causes of encephalopathy, the confusion develops synchronously and quickly. So of all the patients you've taken care of with a urinary tract infection who come in confused, they come in with 1 or 2 or 3 days of confusion rather than a festering course of progressive encephalopathy over a period of time. So the fact that this is subacute is also alarming. And then last but not least, we don't have any extrinsic clues yet. So I would say I'm right there with you. I think we need to start with an external workup. But I would say because of his rich baseline, his asymmetry on exam, the subacute nature of his confusion, and the lack of peripheral clues like cough or dysuria have me worried that we might have to quickly pivot towards something inside the brain itself, which is unfortunate, but I think being ready for it beforehand is really, really key. Okay, Rahul, why don't you give us the next aliquot?
Wonderful thoughts, Ravi and Dr. Mengyu. And let me share my second aliquot. And this patient has a past medical history of CLL on daily ibrutinib, and he has history of hypertension and gout, and family denies there is no accompanying fever, chills, weight loss, night sweats, fatigue, chest pain, palpitations, short of breath, dyspnea on exertion, abdominal pain, urinary symptoms, leg swelling, vision change, any sick contacts, or no, any areas of any skin breakdown. And he lives with his wife. He does not smoke or drink, and working on bathroom remodeling in old house in the week prior. This is the end of second report.
Maybe I can just kind of share a little bit of an illness script for CLL and have you layer on everything else. How does that sound?
Yeah, that sounds good.
Great. So yeah, CLL is a very common condition. It is almost exclusively in patients who are over the age of 50, and its name is very well descriptive. It's literally chronic lymphocytic leukemia. And what happens is there is a abnormal population of mature B lymphocytes, and those B lymphocytes are circulating in the blood, hence the term leukemia. It is a characteristic mutation and a characteristic appearance on smear termed smudge cells. And basically, CLL is very similar to prostate cancer. It is a disease that is very slowly progressive, and most people often die from another reason, and CLL is a bystander, though in some people it progresses. And we know that in this person, it must have progressed because he is on treatment for it. And the criteria for initiating treatment on CLL are essentially that the patient has some sort of consequence of the CLL, either progressive cytopenias, bone marrow invasion, autoimmune phenomena, and so on and so forth. I would say that most patients who do develop consequences of CLL may develop it as a result of the disease, but more so as a result of the immunosuppression required to contain it. So I'll leave it at that and see what you're thinking, Ming.
Yeah, I think the CLL history is very interesting for the reasons that you laid out. I have to, try to remind myself or maybe read more or ask ChatGPT, like, what are the side effects of ibrutinib that I should be thinking of that may be relevant? So, as an inhibitor of the mechanism that is causing the CLL, and so I think I'll have to kind of do a little bit reading on that. But otherwise, the history seems unremarkable, and except for the social history of working on the bathroom remodeling, which I may put aside, but like having to think the link to AMS, I don't see a direct link yet. That could make me think of it's an old house, could be related to like certain heavy metal exposure or maybe some water exposure. But for water or airborne exposure, I would expect some pulmonary symptoms. And for heavy metal, like we could expect more neuropathy or it wouldn't, of course, seems a little acute if that's only like a one time and very recent. So those are where my minds are right now. I'm curious if I'm missing anything, Rabih.
Not at all. Awesome analysis. All right, Rahul, what do you have next for us?
Excellent discussion. And now I can share the vitals. His blood pressure is 155/70, and pulse rate is 82, and temperature is 36.9 degrees Celsius, and respiratory rate is 18, and BMI of 25, and is saturating around 98 at room air. And general exam is not in apparent distress, and HENT exam, no any extraocular impairment, and pupils are equally reactive to light with normal accommodation reflex, and abdomen is non-tender, normal active bowel sounds, no visible surgical scars, and cardiac exam is fine, no murmurs or no gallops. Respiratory exam is bilateral air entry is normal, and with no presence of crackles, no wheezes. Coming back to skeletal exam, there is no evidence of lower extremity edema, and it is warm and well perfused, and joints are non-tender without erythema or effusions, and there's an intact passive and active range of motions without any pain. And coming back to the neurological exam, he's alert every time and he's oriented to name, place, and date. And assessment of the neurological exam was limited due to pure expressive aphasia and is able to follow some complex commands, but there is no nuchal rigidity. Coming back to his motor exam, his strength is 3/5 in right with right finger abduction and 4/5 for right grip. Otherwise, 5/5 in bilateral flexors and extensors of shoulders, elbows, wrists, fingers, hips, knees, and ankles. And his reflexes are 2+ in both upper extremities, and he has absent patellar and ankle reflexes. And because of his neurological impairment or confusion, gait exam was deferred, and cerebellar exam is finger nose. There's no finger nose and dysdadenochasia were within the normal limits. It was pretty normal. And cranial exam from optic nerve till hypoglossal nerve, everything is intact. This is end of my third aliquot.
Yeah, thank you, Rahul. That's an excellent presentation. I think just to summarize the findings of the exam, seems like what's really jumping out is there's pure expressive aphasia, which would localize to brain, like the Broca's region, and then there's also a right-sided weakness in the hand, actually more in the distal limb. So that would localize to the left side of the brain in a region that is pretty close to Broca's. So I think those both kind of make me wonder if there's something in that area and in the left side, because both localize to the left brain, like focal, as we suspected earlier. And also I got a chance to do a point of care reading about ibrutinib side effects, and I found like people are so knowledgeable in the chat, and I think already mentioned like it's associated with like risk of intracranial bleeding, and there's also like risk of infection, as Rabih mentioned earlier, particular like opportunistic infection. So other than that, I think it's related to altered mental status includes like hyponatremia or it's a BTK inhibitor targeting like the B cells. So with those information, I wonder if I think brain imaging is very important. It may elude bleeding, or more concerning for like infection, like more opportunistic infection in the brain that we could sometimes see in HIV. Especially given the lack of fevers, or just making me wonder like a subacute type of infection, like fungal or those kind of, yeah.
I absolutely love that point of care reading. That's so cool. And I think that's real life. And since there is nothing left on the table in terms of your analysis of this case, I'll just reflect, Mengyu, on some operational aspects you might think of in the emergency room. And I think all of us have been conditioned to think when somebody has when we are seeing for the first time somebody with a focal neurological deficit, that we should think stroke until proven otherwise and consider activating a code stroke. And I think here a close assessment of the duration of the symptom complex is really key. And I think when you talk and speak with his wife, you realize this has been going on for quite some time. And so it's a little bit difficult to say, well, did he have a subacute progressive syndrome with now a superimposed acute event, and therefore we should call a code stroke? And I think teasing out whether or not there is acuity here is important. But if you talk to the wife and realize that actually this has been going on for quite some time, the expressive aphasia especially, you might be inclined to say this is a subacute progressive syndrome and not investigate a stroke rapidly. And this goes to show you why ultimately all of medicine is built on a very, very rich history. So you have very, very tough decision to make if you're talking to this patient. And it really depends on their conversation with the wife, whether or not you choose to activate a code stroke. What you definitely will need at some point is very precise imaging of the brain. And I think the question is, what is that imaging? And in this case where there is a very overt evidence of disease in the left frontal lobe based on the patient's expressive aphasia and contralateral weakness, an MRI with and without contrast is going to be very crucial. A CT may miss subtle lesions. An MRI without contrast may inhibit your ability to determine whether a lesion is inflammatory or hypervascular. So I think an MRI with and without contrast is going to be very crucial for this patient. And if you're trying to take care of this patient efficiently, you could just choose to get a non-contrast CT, so on and so forth. But I don't see anything stopping you from doing an MRI with and without contrast. So if you are in a situation where you are able to do that, I think I would just proceed to do that very quickly. The things that you might see on MRI that will leave you with a little bit of regret that you could have made progress on the CT scan is basically a subdural hematoma. And a subdural hematoma presenting in this way would be unusual enough that I think you'd be justified in skipping over that step if you had the resources to do so. And I think the biggest piece of advice I have is everybody's talking about the brain, but let's not lose sight of the periphery, and that most sneaky brain diseases are things that are systemic in nature that spread to the brain. And the systemic element here may be not in the body, but in the patient's pillbox with the ibrutinib. So there already is a systemic element to this condition, which we'll have to pay close attention to. But yeah, I think it's a very, very intriguing case. I'll leave you all with one thought experiment, which is to ask yourselves, how does the lack of headache influence our analysis here? And I think it's a really, really important element of this case that the patient is not complaining of their head hurting. And I think we can reflect about that aspect when we have the image. All right, Rahul, mic to you, my friend.
Loved both of your poetry and amazing discussion. And now I can share some the labs. His white count is 12.6 and red blood cell is 4.11. His hemoglobin of 11, hematocrit of 38, MCV of 92, MCH of 28, and platelet count of 157, and with not 80% of neutrophilia of white count, and sodium of 134, potassium of 4.3, chloride 97, CO2 of 25, calcium of 9.3, B1 of 21, creatinine of 1.39, and glucose of 111. And he also got the CT scan of the head without contrast that showed round area of low attenuation in the left frontal lobe that may relate to the area of age indeterminate ischemic change. And if there is a concern for a mass lesion, MRI would be more sensitive, and no territorial infarct with preserved gray and white matter differentiation. This is the end of fourth report.
I'll take the easy aspect of this case and just say I think the weight of the disease lies in the CT scan, which we'll get to hear Mengyu's thoughts on. But the peripheral analysis is essentially unremarkable, and it goes to show you how having the pretest probability based on the history and the exam can help you guide the workup. So if your pretest probability was that the peripheral workup was going to be a very high yield, you might not have got on the phone with MRI and said, "Hey, MRI tech, nice to hear your voice today. I'm letting you know there's a patient who will likely need an MRI in 2 or 3 hours. Can you please prepare the scanner for that?" And that's probably what you might have done if you were suspicious that you needed it. And I think that suspicion has been confirmed by the relatively underwhelming laboratory data, with one exception. And that one exception is a mild neutrophilic leukocytosis, which has equal probability of being signal, but also equal probability of being noise. So I would make note of that, but would not use that to create my core feature of this case. I think the CT probably has that. So I'll hand the mic to you, Mengyu, to hear your thoughts.
Yeah, very interesting. I think the imaging is so helpful because it helps us distill our problem representation further to now having to solve the problem of this brain occupation in the brain, which explains, I think it would explain all the findings that we had earlier, and this we could presume is a subacute development of this lesion. And I think thinking about like, I think an MRI would be helpful to help us differentiate, because if we see like a complete ring, if it's a ring enhancing lesion, or if it's a complete ring or half ring, I think there are certain features on the imaging that could help us make further progress. But for now, other than that, I think my thoughts for differential for this finding is like infection, and so that can include like TB or syphilis or nocardia and fungal infection, as we mentioned earlier, and including like toxo, but also like certain parasite like neurocystic sclerosis. I think that's less likely, but I think and pyogenic abscess I think is also something that we could think, but I don't know if the course might be too subacute for that. I think so. And crypto, if I haven't, well, actually, so yeah, I think some CNS studies would help us to, if there's like a lymphocytic gliocytosis, for example, certain, and then the features of CFS finding could help us make further progress. Other differentials like include like malignancy, whether it's a metastases or like primary. I think it's less likely, but I think that's on the differential. And inflammatory causes, and yeah. So I think those are my thoughts for now.
Oh, Mengyu, you can't expect me to add anything to that great differential. I have nothing. That was awesome. All right, Rahul, tell us what you have next.
Loved your discussion. Now, because of the concerning neutrophilic leukocytosis and the empirical viral and bacterial meningitis discoveries was initiated with acyclovir, ampicillin with third generation cephalosporin. And he also got the EEG, which was within normal limits. And the next morning, and rapid response was called because of the worsening mentation, and he was intermittently erosible to voice, and he demonstrated right hemi neglect and complete aphasia. And yeah, this is the end of fifth aliquot. So Rabih, do you want to give some more information, or do you think it's a good time to stop here?
Maybe Rahul, to help us pace things, how many more aliquots do you have?
I have three more aliquots.
3 more aliquots. Okay, yeah, why don't you give us the next round of information just so we can have time for a breakout room?
Absolutely. And because of the concerning neurological dysfunction, the code stroke was called an MRI brain with and without that showed an heterogeneous area of enhancement centered within the left frontal lobe and corona radiata with significant surrounding vasogenic edema, which is extending into the corpus callosum and left basal ganglia. And there was a significant interval growth over next 2 days. Yeah, this is the end of the fifth aliquot, I guess.
Oh, wow. Trying to digest the imaging heterogeneous enhancement of in the left frontal lobe surrounding edema. Yeah. I mean, that finding, like my reflex thinking is I wonder if there's so if it's an infection, for example, like a cryptococoma or some collection infection that burst, I think that's the first thing that came to mind. But also if it's a malignancy, whether it's like a glioblastoma or like a lymphoma, like if they might also behave in a way that may like bleed with the heterogeneous and find heterogeneous, maybe there's like intra-lesion bleeding or things like that that could more point towards a malignancy. But like, yeah, I think getting the CFS study is very helpful. I think we might have to be cautious with the change in mental status, thinking about the pressure in this CSF. Have to have some caution there. Yeah, I think I have to like ask myself like what kind of infection might present this way. I think a case I recently read was like cryptococcus or something that could present like dramatic, like with an acute change in the course. And I don't think it's a bacterial, because if it's already covered, then that makes it less likely. And so like what infection could have this acute turn of course? Or is that I think, or is that a more behaving like a complication of a tumor? I think asking radiology to see if they could have some insight in that. And then I think the CFS study will help us make more progress. Yeah, what do you think, Rabih?
Yeah, I'm right there with you. I have nothing to really add, but just to try to share the mental shortcuts that I think we all take, which is whenever you have a brain mass, the differential diagnosis, realistically speaking, is infection or cancer. I do think that the things that can humble you and humble radiologists are aggressive demyelinating diseases, and then occasionally strokes with liquefactive necrosis that look a lot like masses. So if you might remember, we've had a couple of those kinds of cases presented on VMR, but I think the operating hypothesis is infection or cancer. And then one way of distinguishing infection versus cancer is to study the nature of the MRI findings, including the pattern of enhancement and the pattern of diffusion restriction. That is helpful, but is not as helpful as what happens to the mass over time. And if a mass rapidly grows, as Rahul just shared with us, that really prioritizes infection. It does not exclude a rapidly progressive cancer, but in general, when you look at the MRI, a radiologist can tell you, hey, this is a complete ring of enhancement with diffusion restriction. That's pathognomonic for an infection. A complete ring of enhancement with less diffusion restriction is usually cancer. Of course, the location, so on and so forth, are also helpful. So I, like you, Mengyu, I'm fixated on infection. And I think the range of infections that can cause space-occupying processes in the brain are everything except viruses. So you can have bacteria do this, fungi do this, parasites do this, amoeba do this, and even algae do this. So the range of possibilities is enormous. And I think instead of trying to make progress based on that information alone, I think there's two simple things that can help you make a tremendous amount of progress. The first is, who is this person? And what are their host risk factors? Because to get an abscess in your brain, there's got to be something unusual about you. And if you find nothing unusual about the person, often they have a pyogenic brain abscess that happens for no good reason except that they have poor dentition or that they have a subtle PFO that nobody knew. So the question for us is, who is this person? I think the fact that he's on ibrutinib really opens up the door for many opportunistic infections, all of which you've mentioned, aspergillosis, cryptococcosis. But I'd say here the rapid growth and how quickly this is growing is less in keeping with fungal organisms and more in keeping with pyogenic bacteria. So that's a tension there too. So who the host is really key. And the second is, where the heck did this come from? How can you have something make it all the way into the brain, without being located anywhere else? And the most common occult location of a disease is in the lungs. So for me, I think the practical question is, how do you find out what this is? How do you know? And the most foolproof way is to sample this brain mass. And I guarantee you, if you sample it with a good neurosurgeon, you'll know what it is. So the only question right now that we're faced with is, how do we get diagnosis without sampling it? And if we have to sample it, we have to sample it. And there's only, I think, two ways of having any hope. The first is the patient has a peripheral clue with lung disease as the most common cause, or the patient has the answer in their blood, either a positive blood culture or a positive cryptococcal antigen. Or in some cases, a positive RPR. Syphilis can do crazy things in the brain. So realistically speaking, I think now is the time to say, what's going on in the lungs? Is there a clue there? And if there is, I think that'll change the calculus quite significantly. Some people would be inclined to put the patient on broad antibacterial coverage because response to treatment can be a clue that the patient has a pyogenic brain abscess. And I think this patient will probably be put on anti-seizure medications because of the high risk of seizures and his episodic encephalopathy. So a lot of work to be done. I talked a lot, so maybe we can hand the mic to you, Rahul, to give us the next aliquot, and then we can slow down and reflect on it.
Excellent discussion. Now I can share next aliquot. And lumbar puncture was performed in neuro ICU, and LP showed 14 RBC and cell count of 1 and protein of 65, which is elevated. And also isavuconazole was added to empirical regimen of the other medications. And other multi-organism PCR is negative, serum galactomannan negative, serum beta D glucan negative, Bartonella, Coxella, Borrelia antibody negative, West Nile virus PCR negative, and Toxo PCR CSF negative. And again, interval CT showed a continuous interval increase in hypodensity surrounding the frontal mass with increased mass effect on the left lateral ventricle. No significant midline shift, and findings may be related to the worsening infectious processes. Because of these new findings, and coverage was changed to meropenem with IV trimethoprim sulfamethoxazole along with liposomal amphotericin B. Because of this worsening mass effect, and the patient went to the OR and underwent left decompressive frontotemporal craniectomy, and brain biopsies were taken in the OR. And the next aliquot will reveal the diagnosis, Rabih.
Wow, what an interesting case. I forgot whose turn is it, but I'm happy to share my thoughts. First, I was surprised with the CSF of only one cell count of 1. Is that true? Like, which almost feels like, because the picture all fits with infection, but then there's only if the it was 1, like almost like the albumino or cytologic dissociation, which would more points, which is not specific, would more point towards like a demyelinating process, which doesn't seem to. I would doubt that findings. I'm actually surprised at what kind of. I think I still want to complete the infectious workup, including a CRAG and additional pathogens that we kind of mentioned in the previous discussion from CSF studies. But I have to think about albumino cytologic dissociation. Is that something? So it's like non-specific, could be mostly in the inflammatory conditions, or um, yeah, I'm trying to see if there's like something, some disease that cause like the GBS like illness, including malignant leukemia, lymphoma, or Lyme disease. But I think there's a tension here that I need to I'm like questioning like how much weight I should put on that cell count.
Yeah, well, not to interrupt you, Megan, but maybe we can do this since there is such a powerful tension. Why don't we do just 2 or 3 minutes of breakout rooms for you to percolate in your thoughts, for me to do the same, and then we can have people intermix their thoughts and ideas. Does that sound okay?
Yeah, that sounds perfect.
Okay, all right, I'll pause the recording then. Hey, welcome back, everyone. I hope you had fun conversations in your groups. So, Mengyu, what are your thoughts?
Yeah, I think one thought is that maybe repeat the study to see if it's accurate, like with the cell count. And second, I was trying to look for like what infection could cause like a very low, underwhelming WBC. And even though underwhelming, I usually think they still have elevated, just maybe mildly elevated, like in double digits, which includes like spirochetes and maybe even crypto sometimes. But this is still surprising if it's truly accurate. And then I really haven't seen CNS demyelination diseases presenting this way, but of course I don't have a robust exposure to those cases, or so I think the pathology, I think it's fortunate the patient already had a brain biopsy. I'm sure that will reveal the diagnosis. And otherwise, if we don't have that, I wonder if like pathology in the CSF would help us
Yeah,
to rule
right.
out some concerns for malignancy. Yeah, I'm curious to learn from this case.
Yeah, I think it's an interesting question to ask yourself. What is the pretest probability of pleocytosis in the LP? And I will tell you my honest sense, at the risk of being different from what seems to be the majority of people in the audience, is I wasn't expecting it to be very high yield. And let me try to explain why. I think that whenever you do have a process that's going into the brain, it's very helpful to say, is it in the parenchyma, like a cancer? Is it in the vessels, like GCA? Is it in the ventricles, like neurocysticercosis? Or is it in the meninges? And it is true that many metastatic diseases of the brain involve multiple compartments. But meningeal involvement, while the most common, is not uniform. So if you ask yourself, what is the rate of meningeal involvement in autoimmune encephalitis, where the disease is raging in the brain parenchyma? It's pretty low. The same is true for CNS vasculitis in the vessels. And so I think that when you do have a space-occupying process in the brain parenchyma, the degree of meningeal involvement depends on the underlying cause, but generally is pretty low. So if you look at the rate of positive lumbar punctures in patients with pyogenic brain abscesses, it's less than 10%. If you look at the rate of lumbar puncture positivity in patients with glioblastoma multiforme or CNS lymphoma, it's also pretty low. It is actually a profound diagnostic clue when the patient has synchronous meningeal and parenchymal disease at the same time. So if the LP were to show a very high pleocytosis, I think cancer would be highly unlikely, because cancer usually does not spread to both compartments. And a very small number of diseases have a tropism for the meninges and the brain, and that a small number of diseases is essentially cryptococcus and tuberculosis. There are others that do it, but if this LP showed a lot of inflammation, I'd be more worried about cryptococcus and more worried about TB. But so I think the progress that you can make, Mengyu, with this lumbar puncture is to say that this is a disease that has profound tropism to the parenchyma. And this is, as an example, characteristic of a pyogenic brain abscess. It's also characteristic of nocardia, and it's characteristic of molds, which really love to go to the brain parenchyma and don't go so much to the meninges, in contrast to cryptococcus and in contrast to the endemic mycoses, which go to both. So I think it's a very powerful clue to say, hey, this is a likely infection based on how fast it's growing, but it could be a necrotic tumor for sure. And it is an infection that seems to have so much more tropism for the brain parenchyma than it has for the meninges. And so I think in all comers, this would be a classic case of a pyogenic brain abscess. But because this person's on ibrutinib, I think we have to entertain unusual infections like nocardia. But I think that the association with nocardia and ibrutinib is not as robust as it is with fungal organisms. So if we apply the filter of fungal organism plus rapidly progressive, I think that's where you get into the world of angioinvasive molds like aspergillus. So for me, I think the truth is it's not important to know what bug this is or what cancer is. It's important to know, I think, that the way to an answer is to try to avoid doing a brain biopsy and to ask yourself, where else is this disease? And to realize that in some people, it's only in their brain and your only chance is to biopsy their brain. So I think I would accept a nocardia diagnosis. I would accept a pyogenic brain abscess diagnosis. I would accept a necrotic tumor diagnosis. I would accept aspergillus. But I think the most characteristic presentation, I think, evolving here is a patient who's on ibrutinib, who has an isolated parenchymal disease that is rapidly progressive. I would worry most about a mold. But really, really curious to see what the outcome was in this case and what we can learn from it for sure. Mike, to you, my friend.
Wonderful discussion. And honestly, I feel this is one of the toughest cases in the VMR. And you guys really nailed it with all the reasoning. And apparently, brain biopsy pathology was consistent with amoebic encephalitis, and the organism was identified as acanthamoeba. And this case was discussed with the free living amoebic team at CDC, and they recommended initiating empirical treatment, including azithromycin, sulfadiazine, flucytosine, fluconazole, and miltefosine. But unfortunately, the patient neurological status continued to worsen, along with the worsening kidney function and respiratory failure. And the palliative care team was consulted, and the patient was transitioned to the hospice care. Yeah, unfortunately, it happened, but I really want to thank Yusuf for sharing this fantastic and amazing case. And I really loved Dr. Stravis and Dr. Mengi's discussion. And I have few teaching points, which, Yusuf and I was chatting about how this patient got this infection. And amoebic encephalitis it's a very rare CNS infection with only 109 cases reports of Balmuthia between 1974 and 2016, and 157 cases of Naegleria between 1962 to 2022, and 173 cases of Acanthamoeba. But to the current literature available, this is the third case of amoebic encephalitis in a patient with ibrutinib, because patients on ibrutinib will be considered to susceptible to rare and commensal organism in addition to common infections. And also because of his occupational history of renovation and remodeling, there could be other possible risk. Yeah, thank you so much for the great opportunity to present and learn from you today.
Oh, that's hard to believe that you weren't there. I think you presented this case in a manner that was like where you were right next to the patient. Yeah, Mengyu, I'm curious what your reflections are.
Yeah, thank you so much for the case, Rahul and Youssef. Yeah, I think the final diagnosis is a little bit surprising, but I think it still fits the pyogenic infection. It's just a very unusual organism that we rarely see. I associate that with like corneal ulcers, but all the amoebas could cause granulomatous infections in the brain. But I really love the journey where I think one friction point I wasn't familiar with earlier was like when the brain infection only involves parenchymal, like how the CSF could be looked completely lacking cell count. I think I wasn't aware of, or I wasn't familiar with that. So I think it's very helpful for me for future cases like this, to know how to make progress from there. But I'm also curious, how did the patient get this infection? Because I associate amoeba, acanthamoeba, like with maybe water exposure. Maybe that's like a different type of amoeba, like the Fowleri, whatever. But I'm curious how like people get this infection. But it's a really interesting case.
Yeah, I'm right there with you. My reflection is essentially captured in probably the following visual, which is on RLR CP solvers, but it's a very dense visual. But I think to help orient you, the top, moving from left to right, the probability of a brain abscess increases. And moving from right to left, the probability of meningeal involvement decreases. And the time course from right to left increases. So as an example, a viral infection of the brain is usually low risk of an abscess in the brain, very high risk of meningeal involvement, and very acute time course. And the further and further and further and further you move, everything switches. So by the time you get to amoeba, there's a very high rate of brain abscesses, very low rate of meningeal involvement, and often a subacute time course. The problem with amoeba is that they have no other way of diagnosis except a brain biopsy. And so you often, and really no good treatment, unfortunately. So it's a horrific outcome for this patient. I would encourage you all never to prioritize an subacute amoebic infection until you've ruled out these infections, because these are treatable, more common, and they often have easier ways of diagnosis than a brain biopsy. And it's unfortunate that this patient went all the way there. But if you were to fine tune your reasoning for the next case and refine it from this case to say, oh, I should have thought about amoeba earlier. And that's true. You probably should think about it earlier. But is that knowledge actionable? No. Because if you think about amoeba too much too early, you'll skip over the importance of looking at the chest CT to look for nocardia, which you can treat, aspergillus, which you can treat. But I think what is my fine tuning here is I had not learned or did not know at all about the association of acanthamoeba with ibrutinib, and that's a really helpful piece of knowledge. So going forward for me, what will this case change? I think it just reinforces the point about the idea to do everything you can short of a brain biopsy. But if you have to do a biopsy, you have to. And some of the things you'll find include acanthamoeba, and I'm really curious to learn and understand more the connection between that and ibrutinib, which I had not heard of before. But a really, really tragic and unfortunate case with a lot of really cool learning points. Is there anything else you wanted to reemphasize, Mengyu, before we hear from Lyra about how she's uploaded this all?
No, I love your schema, realizing the spectrum of how CNS involvement could present with, from our more commonly seen meningitis to like isolated parenchymal involvement in the form of abscess, and then how that would change our CSF analysis. I think is something I will take away for sure. Yeah, I'm here. I look forward to Lyra's excellent teaching point. Looks so organized.
Thank you, first of all, Yusuf and Rahul, for this incredible case with so many twists and turns that brought us this amazing discussion. So the case started off with a 75-year-old patient who presented with confusion. And with that information, we built our approach to altered mental status, which is how we framed this presentation of a patient. And we need to firstly determine the time course of the altered mental status. Is it acute, subacute, or chronic? Because all three compartments have very different differentials. Next, we need to think about why this patient is confused. And here we have a very helpful missed mnemonic. But the main question we need to ask, what is the precise probability of extracranial problem versus intracranial problem? And here we have a relatively wide spectrum of information to help us determine that. We have a patient's baseline, which was absolutely normal. We have a subacute time course. We have minimal additional symptoms outside of the brain, and we have some presence of asymmetry on the exam with some signs that can be suspicious for localizing focal neurologic signs. So with this information in mind, we right on the first aliquot prioritized the central nervous system problem versus the external problem. Then we discussed the patient's background, and we have a really important piece of information here is that the patient has diagnosis of CLL, and we need to ask the question, is this disease progressive? Because it's usually slowly progressive, but not in this patient, because we can determine the spectrum of progression of the disease by the fact that this patient is already taking some treatment for this disease, which means that it was most likely progressive. And we can think about these implications into our current problem, but also think about side effects from the treatment that patient is taking. And the most common side effects, the most important side effects of this treatment in the current problem were the high risk of intracranial bleed and also high risk of infection, which was really, really important here. Next, we talked about the brain problem. And first, we need to localize where it is. Because we found some asymmetry in the exam, we found expressive aphasia and right-sided weakness. And with that information in mind, we determined that the disease lives in the left frontal lobe. And the next piece of information that we discussed is really, with this asymmetry on the exam, do we need to call the code stroke right away? And here the time course is really key. If this is just a progressive subacute problem, we don't need to worry much. But if there is superimposed acute syndrome on this subacute problem, we can think about calling the code stroke. Next, we talked about the importance of the imaging in this case, which can help us narrow differential down to imaging positive or imaging negative CNS pathology. And we talked about the choice of the imaging and the importance of the MRI with and without contrast in this case, compared to the information that we can get with the CT. And the choice of imaging can really help us to answer this question, the previous probability of subdural hematoma in this patient, which here was pretty low. On imaging, we noticed that there was some space-occupying lesion, which basically we framed as a brain mass, and we talked about differential diagnosis for the brain masses. And when we have this piece of information, we basically have two options in mind, malignancy, and the second is infection. And in terms of infection, this really can be anything except viruses. And the gold standard test to determine the etiology of this brain mass would be the brain biopsy, but we need to avoid this at all costs. So how do we get a diagnosis without tissue sampling? First, we need to determine who is the host and what's his past medical history and what risk factors he has. And here we have a really profound clues to immunosuppression on current treatment that the patient is receiving. Next, we can analyze the CSF studies. We can also look for imaging clues for pattern of enhancement and diffusion restriction, and also a very important clue would be the mass growth over time, which in this case was really profound, which increased our pretest probability for infection. And if we're talking about and thinking about infection, we really need to search for a source of infection. And if this is occult without minimal peripheral findings and symptoms, we really need to think about lungs. And also we need to look for clues on the periphery, for example, with a bunch of blood tests that this patient was getting. And also we talked about CSF analysis, which showed very low amount of cell count in this case. And this was kind of unexpected. And when we have unexpected finding, we can consider repeating the test. But also we need to think about where does the disease live, because we have 4 compartments in the brain, which includes vessels, ventricles, parenchyma, and meninges. And we really will see the CSF changes when we have the meninges involvement, which is most common cause of CNS infection, but it's not universally seen in all CNS infections. And talking about that, we talk about infections that like to cause simultaneous meningeal and parenchymal involvement, which differential for which includes cryptococcus, endemic mycosis, and TB. But in this case, we've seen the profound brain involvement with minimal meningeal involvement. And this differential included molds, nocardia, pyogenic brain abscesses, and amoeba, which was the final diagnosis here. And that's it.
Are you tired? That was unbelievable. Such an outstanding job. We captured everything and more. Thank you so much, Laura. Thank you to all of you. It was a real treat to discuss with you, Mengyu, and really appreciate your case, Rahul and Yusuf, and of course, Noah for scribing. Have a wonderful rest of your day. See you guys later.